And I want to mention that this is really a companion talk or a complementary talk to Dr. DeBarber's talk yesterday and Dr. Wishart's talk that's coming up later today. So all these are on the topic of CTX, or Cerebrotendinous Xanthomatosis. And in particular, as it relates to Dr. DeBarber's talk, this systematic evidence review that I'm going to tell you about is the motivation for this is the goal of having CTX be a disease that is screened for on newborn screening. And the data that we're hoping to put out from this systematic evidence review is really guided by the requests from what will be needed to support CTX as a newborn screen diagnosis. So I have a couple of disclosures related to working on clinical trials. Specifically, the application for CTX to be on the recommended uniform screening panel was submitted in 2018. And the feedback based on that submission was that the panel requested clarification of the definition of what should be considered a true diagnosis of CTX, as well as evidence for the clinical utility of pre-symptomatic diagnosis and information on which patients among those with a diagnosis of CTX should be treated. So the approach that we used was guided by a couple of methodological experts here at my institution, the University of Colorado, that included Patricia Hine and Christy Piper. We surveyed the English language literature. We decided to include both case series and case reports that included at least one individual with a confirmed CTX diagnosis. We included all years of publication, and we considered a CTX diagnosis to be any two of the three of typical clinical features, typical biochemical findings, and biallelic CYP27A1 mutations. We excluded conference abstracts and excluded publications where a diagnosis of CTX was not confirmed. We reviewed titles and abstracts, followed by full text review conducted by content experts. We also scored the quality of these publications. The folks doing that scoring were Dr. Shailesh Patel, Dr. Bob Steiner, Dr. Andrea DeBarber, and myself. And then we got help from a few folks that work with Cochrane. They're experts in development of databases based on systematic reviews. And those folks were Tiffany Duque, Ana Pizarro, and Andres Riquarte. So we developed a database from 248 publications that met our inclusion criteria. The database includes the genotype for those patients that had genetic diagnosis. It includes metabolic abnormalities, including the metabolic response to treatment. It includes the clinical phenotype across both neurologic and non-neurologic domains, whether a patient was treated, subjectively whether the authors reported a response to treatment, and side effects of treatment. We excluded, as much as we could, we excluded duplicate patients who were potentially published in multiple publications. And at the end of this process, from those 248 publications, we felt like there were 1,054 published patients. Of those, 873 had case level data that was resolvable at the individual level. That means that some of these publications included patients only with aggregate data that couldn't be resolved down to the level of the individual. So there were a few patients with a clinical only diagnosis that made it through our process, but as was the goal, the vast majority of these patients had either a genetic or biochemical diagnosis or both, including 475 patients with a genetic diagnosis. The non-neurologic symptoms that we saw for patients with CTX, so this is out of 873 patients, The vast majority of them had documented tendon xanthomas. About 2/3 had cataracts, about half had diarrhea, and 5 to 10% of patients had osteoporosis, liver disease, and premature vascular disease. Among the neurologic symptoms that were documented, about 2/3 of patients had cognitive impairment, about half had ataxia and spasticity, about 1/3 had at least one psychiatric diagnosis, and about 1/4 had seizures and neuropathy. The majority of these patients that were published had been treated, and almost all of the folks that had been treated, with a few exceptions, had been treated with CDCA plus or minus other medications. About half of those that were treated, the authors of the paper reported any subjective or objective improvement for the patient after the initiation of treatment. So one of the ways to evaluate the value of this database and the reliability of the data that were abstracted is to compare to a few other papers that ascertained cases in a little bit of a different way. So this is a publication from 2018 from Dr. Duell, and this is more of a first-hand data collection for 43 cases. The authors directly spoke with treating providers for these patients. And by and large, they found quite similar phenotypes for CTX. So that included the fraction of patients that had diarrhea, the fraction of patients that had cognitive impairment, cataracts. There was a few more with tendon xanthomas in our systematic evidence review. And my interpretation of that is that we included data from papers that were published sometimes 20, 30, 40 years ago. For those older papers, the xanthomas really were considered one of the key diagnostic criteria. And in the era prior to broad genetic testing, where diagnoses can be made in maybe some less typical or less expected cases, the older cases really disproportionately have xanthomas. The reports of improvement with treatment were very similar, as well as the prevalence of premature vascular disease. A second paper to compare to also did a systematic review, although they limited it to the last 20 years. So with that lens, that was 568 cases. And again, you see a very similar breakdown of the prevalence of different symptoms for published cases with CTX. Again, you see the difference in the prevalence of xanthomas, which, as I explained, is likely a function of the cases that were ascertained longer ago. Lastly, I wanted to make the point, and this is a paper from 2018 published by Dr. Eichler and his colleagues. I wanted to make the point that the age at which you ascertain an individual with CTX is really informs what you perceive the phenotype to be. And the reason for that is that this is a progressive disease. So Dr. Eichler and his colleagues were able to identify the age of onset of each of these symptoms and show that for all of the characteristic symptoms of CTX, there's an age-dependent penetrance. So the likelihood that someone with CTX has ataxia at age 20 is very different than the likelihood that they are manifesting with ataxia at age 60. So this is something that we hope to do, maybe in a slightly artificial way with this systematic evidence review, is contribute to this understanding of the age-dependent penetrance of different aspects of the clinical presentation of CTX. A couple of recent publications that I think will be complementary and that can be used to kind of deepen and get a more nuanced analysis of the data that we have here include this publication from Dr. Penelope Bonin and her colleagues about the potential or the calculated prevalence of CTX based on looking at the carrier frequency for known mutations. At the time of this publication, it was what's called the XACT database that has been updated to what's called the NOMAD database. And now that we've collected some additional known pathogenic variants that cause CTX, we may be able to update this analysis. And one particular aspect of this that I'm excited to take on as one of the first projects using this database is to look at atypical cases of CTX. So these are two recent publications. In the upper left is a publication from Stelton and colleagues. They presented, I believe it was 19 adult individuals without neurologic manifestations of CTX. And they have genotypes for all of those individuals. I'd be really interested to use those genotypes that they published as being associated with maybe a milder or atypical or non-neurologic presentation of CTX and see what we can find in the database from the systematic evidence review to see if those genotypes actually have a reproducible genotype-phenotype correlation across additional cases. Likewise, a different type of atypical CTX presentation was published by Gwenzel and colleagues. These were individuals that lacked the typical biochemical findings, so they did not have an elevated cholestanol, which is considered a characteristic feature of CTX. So for these patients that don't have an elevated cholestanol, they presumably have what's called hypomorphic mutations that allow a little bit more enzyme activity to exist despite the presence of the mutation. Again, these are genotypes that we can now look for throughout our database and see what the correlates are in terms of clinical features for those patients. So the strengths of this approach are that it includes a larger number of patients, both temporally and geographically. We may be able to increase the sensitivity for looking for these atypical genotype-phenotype biochemistry associations. The fact that we have 475 genetically diagnosed patients is a big strength of this database and may allow for some of the type of analysis that will be needed to make the case for CTX to be on the recommended uniform screening panel. However, there's a downside to having this kind of maximalist approach to data collection, and that is that the quality and the completeness of the data are quite heterogeneous. The data are mainly cross-sectional and not longitudinal, so we just kind of have a point in time for most of these patients. And medical care was quite different 30, 40, and 50 years ago, so we had to be careful about how much we extrapolate from the course for those patients. Next steps, as I mentioned, are to kind of get at the age-dependent penetrance of different aspects of the phenotype of CTX, look for specific genotype-phenotype correlations, look for documentation of biochemical improvement with treatment and see if that correlates with clinical improvement. We can, across a really large number of individuals, over 600 individuals treated with CDCA, look for the rate of adverse events with treatment. Again, look for these kind of atypical cases, these edge cases that are a big concern when you start ascertaining cases at the level of the entire population by doing newborn screening. Many more of those edge cases or atypical presentations become part of the understanding of the natural history of the disease. So if we can get out in front of that phenomenon and proactively kind of know what we might find in terms of atypical cases. So in summary, there are many more published cases of CTX than previously documented, and this database of individual level biochemical, genetic, phenotypic, and treatment information will help to facilitate new analyses that will strengthen the application for inclusion of CTX on the recommended uniform screening panel. I really want to thank Hunter's Hope for providing funding for this project, and the folks that worked on it: Andrea DeBarber, Bob Steiner, Shailesh Patel, Patricia Hine, Christy Piper, Tiffany Duque, Anna Pizarro, and Andres Riquarte.